Welcome, everyone. We're so glad to have you here this evening at Gilda's Club Kansas City as we have Linda Mufich, PT, with us tonight and Certified Pelvic Rehab Specialist on our women's pelvic health after cancer treatment. And with that, Linda, I'm going to pass it on to you.
Okay, thank you everyone for coming tonight. As Anita said, I'm a pelvic health certified specialist, and I'm not sure if you all knew that there was such a thing, but it is a specialty area of physical therapy. I've been a therapist for 37 years and in women's health for the last 23 years. So I'm going to go ahead and share my screen, which has information about me, and we'll have a slideshow. So hopefully this will be smooth. All right, and then I'm just going to put it on slideshow, large screen here. All right. A couple more clicks. And then I think I'm just going to move. Yep, I got it. I'm moving the little pictures. All right. So here's my screenshot, women's pelvic health and cancer treatment. I did have after cancer treatment, but I'm understanding that some of the audience might still be going through cancer treatment, and some of these pelvic health issues can start while you're in cancer treatment. But most often, as a survivor, you will say, oh, yay, I beat cancer. And then all of a sudden you find that maybe months, years later, you have other pelvic issues that you have to deal with. So that's why we're doing during cancer treatment and then after. My small clinic, private practice clinic, is called FemFocus PT down here. That's how you can find me on the internet, femfocuspt.com. I've been a solo practitioner for the last 4 years. And prior to that, in women's health, I worked at the Shawnee Mission Medical Center and was their pelvic health therapist. Thank you to Gilda's Club for inviting me back to give this talk. It is very important for cancer patients and cancer survivors to know this information. In the past, I think I've given it with both men and women, which the anatomy here is quite different, and it was just a lot of information, a little bit overwhelming. So thank you, Gilda's Club, for allowing me to kind of break it up. I did a male pelvic health earlier, I think it was February, March, and now we're focusing on the female pelvic health. So pelvic health, most of you that signed up probably have issues, so that's why it caught your eye. But to the general public, if you say pelvic health, they may not know what you're talking about. Though they've heard things like heart health and they've heard things like bone health, and those two things ring true in their ears. You probably ask the general public, hey, give me one little fact that you know about to keep your heart healthy, or hey, what do you know about keeping your bones healthy? And so health in general is medical knowledge that's kind of trickled down from all the research and the studies and past experiences now to become part of general knowledge. So if I asked you, the audience, give me one fact of heart health, you would probably name, oh, you're supposed to watch your blood pressure, try to cut back on your red meat and your fats, exercise, do aerobic exercise to get your heart and lungs pumping. That'll keep your heart healthy, keep it within a reasonable heart rate while you're doing that exercise, and yada, yada, yada. So I think those things are now in the general public, because earlier on in the 60s and 70s, we had all kinds of people having heart attacks, and we've studied and learned from that. But by now, it's just general knowledge. Same thing for bone health. When people started falling, fracturing their hips, and osteoporosis was researched and became more talked about. Now you probably know for bone health, you're eating green leafy vegetables that have calcium in it. Calcium goes in your bones if you take vitamin D and vitamin K. Be careful, fall-proof your home so you don't fall and have a hip fracture. And then also exercise. So for bone health, most of us know the exercise has to be weight-bearing exercise, where the ground hits the foot hits the ground, so that ground force stimulates the bone to build up. So each kind of body part to keep them healthy has a particular type of exercise for it. Pelvic health, a lot of people are like, what is that? Because we're going to be talking about the three main organ systems in the pelvis meaning below the belly button here and above the groin. And so we're talking about bowel, bladder, and sexual function. So pee, poop, and sex. And so a lot of people don't talk about those things, but the knowledge is there. These problems have been researched. They're very prevalent. They've been happening for centuries and centuries. We just don't talk about them. So I think what you're going to get from tonight, I hope you finish this little lecture and you have a few factoids of your own now that you know what is generally good health for this area of the body. And if you have a problem, you really need to know that. What's the best thing to take care of yourself to help your problems or avoid problems? Okay, so that's what pelvic health is. So why is a physical therapist talking to you tonight? Well, this area called the pelvic girdle, again, below the belly button and above the groin, is highly musculature. If you can see here, I've got my own bony pelvis, and you see it on the slides as well. So you've got the hip socket, you've got your hip wing bones, you've got the tailbone in back. And then in this area, your pelvic girdle, you have the largest muscles of your body, your gluteals. Everybody's heard the gluteus maximus. They're coming off of the back of your hips. And you have the deepest muscles in your body, deep, the pelvic floor muscles. There you're looking down through the middle of the body. And then yes, between the legs into the genital region, you have muscles. So most people don't realize how muscular this area is. And physical therapists, muscles are our bread and butter. We're the specialists in movement and muscles. So that's why I can talk to you about pelvic problems. And then also this region of the body, the bones form a bowl, a bony bowl for three organ systems to sit in here. So you can see it's kind of like a pelvic cavity. Just look at that, how small it is, and know that three organ systems, bladder, reproductive, and then bowel, have to fit in there. Think about this in comparison to your rib cage and your thoracic cavity. Your ribs form a cage to protect your heart and lungs, but that's only two organ systems, and the ribs are much, much wider and larger than this pelvis. So nowhere else in the body but the pelvis are the muscles, bones, and joints so closely related to the organs. So they feed off of each other. When I started learning about this area of the body, it seemed like those organs and the muscles and bones are almost like an orchestra. They all have to sit in the right section, and they all have to come in on the right cue to have proper functions, bowel, bladder, and sexual functioning. So as a physical therapist, that's why I can talk to you about organ functions. And then again, when we talk about general health of an area of the body, health usually means some form of exercise, like we talked about. For heart, it's aerobic. For bones, it's weight bearing. And for pelvic health, we're going to be talking about pelvic floor exercises, or what are commonly called Kegel exercises. And we'll get onto that in a little bit. Some of you might already have heard about Kegel exercises. And then also, therapists, the word therapy or thera is either Greek or Latin, meaning to work through, thera, to flow and to work through. So we as therapists always want to give you ways to help yourself. And so PTs are pretty much experts in exercise and teaching you self-care. So that's why I'm up here versus, like, say, an oncologist or a pharmacist or a gynecologist. So given that, I do know a lot about organ functions, and I do know a lot about the surgeries that this area undergoes, say for cancer or for gynecological problems. And I do know a lot about the medications that are given, but you'll probably hear me say, if there's a truly medical question or drug question, I'll do my best, but I'll probably say, check with your pharmacist or check with your doctor about that. Okay. Pelvic health problems, we talked about bowel, bladder, and sexual functions, but I thought it was important that you all knew the actual medical diagnoses that go with these problems. So, because you might see them if you get your medical records or you get your chart, or you might hear your doctor say them, or he or she might hand you a prescription pad with a diagnosis. And so you will see and hear these diagnoses, and I thought it was important to cover them. The first one there is urinary or fecal incontinence, fancy medical terms for having stool or bowel accidents. Okay, you can have both. If you're so lucky to not have that problem, you can also have an issue called bladder or bowel urgency and frequency. You're not having accidents, but the urge to go can be so sudden, it catches you off guard, so strong in comparison to maybe the amount of urine or stool you have in, and can also be quite painful. So there's some people who their bowel or bladder urges are strong and painful. And then frequency is an actual medical term, bladder or bowel frequency. You will learn right now a little factoid, general knowledge of normal pelvic health. What is a normal frequency of urination for the bladder? Well, for men and women, it is a bladder, normal sized bladder should be able to store between 2 to 4 hours of urine before emptying. Okay, now some of us go more frequently than that, or might go more frequently if we're drinking certain things that might make us go more, but that's the norm for urination. What's the normal frequency of having a bowel movement? Here's another factoid. So you're learning all about pelvic health already. There is a myth about having to have a bowel movement every day. You don't need to have a bowel movement every day to be normal. So if normal for you is skipping a day or two, as long as when you do pass stool, you don't have any troubles evacuating, you push gently and it comes out, you're not straining and you're not having bloating because you haven't gone. So there is really no norm for bowel frequency. There's a lot of people who swear, of course, you'll feel better every day if you eliminate. But there is no norm right now. It's kind of variable. You can go multiple times or you can skip a day or two. Now, skipping 2, 3, 4 days, I'm assuming those people will have some bloating and will have some difficulty evacuating. Those are storage problems, but you could also have emptying problems, emptying difficulties. For example, some people describe what they call, oh, I have a shy bladder. I've always had a shy bladder, which means you know you have to go, but it takes a while to start. It's very hesitant. Another emptying difficulty for the bladder would be you start right away, but halfway through your stream either stops cold or it kind of intermittent start, stops, and then you end up not fully emptying. So for bladder, the actual medical diagnosis, if you have an emptying problem, is called a voiding dysfunction. And then constipation is a true medical diagnosis when you have trouble evacuating bowel movements. You're straining and you have bloating and other symptoms going along with it. Another pelvic health problem we're going to talk about tonight, the layman's term, especially among women, if you've talked with women friends, is, oh, I had to have a bladder surgery. My bladder dropped. So there are problems called prolapsed organs or dropped organs, because we already know there's 3 organ systems in the pelvic cavity. A lot of things can start to descend and sink down into that pelvic cavity. The medical term for if a bladder drops and descends is a cystocele. If the uterus drops, it's a prolapsed uterus. The rectum can descend and come down low, and you can have emptying difficulties. Is called a rectocele. It could be just the urethra. The urethra in women is a small, like 4 centimeter long tube, and it should be straight for the urine to come out from the bladder straight out. But sometimes for different reasons, and we'll talk about why, instead of a straight tube, it can be kind of saggy. So that's called a urethrocoele. I'm going to try to use my pointer here. This open area is the pelvic cavity, and that's where those 3 organ systems are housed tightly in there. Above the pelvic cavity, where you see my arrow now, is the abdominal cavity, where your small intestine is. And sometimes, lo and behold, a loop of the small intestine can slip down into the pelvic cavity, and that's called an enterocele. And then a vaginal collapse or a vaginal prolapse is called a vaginal vault prolapse. Sometimes that's hard for people to kind of visualize, but think of it this way. The vagina is a canal to the cervix and the uterus. So say a woman had a hysterectomy and they took that uterus out, but the vaginal canal, now where does it end? So sometimes after a hysterectomy, the vaginal canal can kind of fold and start to fold in on itself, and that's called a vaginal vault prolapse. The last three pelvic health problems that people can experience are here, and these three are sexual dysfunctions. There is a medical term for painful intercourse, which is the number one sexual dysfunction. It's called dyspareunia. You can look it up. It's been studied and researched a lot. Intercourse should not be painful, so please advocate for yourself. If something's feeling different going on, talk to your doctors, ask them what can be done for your sexual health. The other sexual problem here is called anorgasmia, meaning inability to climax. Orgasm is a muscular phenomenon. So when we start talking about the pelvic floor muscles, you can sometimes correspond a weakness in the muscles to lack of climax sensation. There's a lot more complications with nerves and things, but just wanted to put that in there that it can be a weak muscle problem. And then PGAD, this is kind of a new diagnosis. It's been around, but I think it's probably getting more researched, and you'll see more treatments in the future for this. Persistent genital arousal disorder, meaning that there's a constant sensation for women in the clitoral area of tightness, almost like they're aroused, but constantly in the clitoral or pelvic region to an uncomfortable degree. Now, if someone was very unsensitive, they'd say, oh, well, what's wrong with that? You're aroused all the time. Well, if we're talking painful and constant. Interesting, you will see a lot more research in this area, but the sensations that we feel and we sense, we feel them in the brain, but we're getting signals from other parts of our body. So those signals come from the nerves in this area. So either the nerves don't fire enough and you don't feel anything. That's what can be happening in this anorgasmia. Something's wrong with the nerves and they're not firing to get to the muscles to climax. Or maybe they're firing too much so that constantly they're feeling something that they're not aroused, but yet they're feeling it. Why would nerves fire constantly? Well, nerves can be under pressure, so they're like little wires. So if they're pulled or tugged, perhaps by a surgical scar, perhaps by a tight muscle, they can fire constantly. So these are complicated, but keep your eyes and ears open. You're going to hear more research about them, but they are pelvic health issues. Okay. How prevalent are these issues? I know my descriptions might sound like, oh my gosh, these are all horrible things, but you can always have them to a certain degree, a little bit, or more severe. And then if something like this is happening with you, you are not alone. People don't talk about it, but look how prevalent. I know I broke the number one rule. You're not supposed to have a lot of things on a screen, but I just wanted to throw these statistics at you because just kind of confirming that if you have these issues, you're not alone. Talk to people, talk to your healthcare providers, see what can be done. I guess the biggest one that you could see here is women, because of our anatomy and our childbirthing, we have more pelvic problems in general versus men. And the numbers are 1 in 4 women, and that's of any women. So we're talking of any age, cancer or no cancer, had babies or not had babies. So that's pretty high, but look at this statistic. In less than 30 years, it's predicted that 1 in 3 women will have problems here. And then the top statistics here are not related to cancer at all. These two statistics are, again, women in general. The most common pelvic health problem for women is the leaky bladders. So 1 in 10 women of any age have bladder leakage sometime in their life. It might be transient, it might come and go, or it might be constant and progress. And then after menopause, 1 in 5. Bladder leakage is not a given as you age. It's not normal, or it's not like, oh yeah, I'm gonna have it, but it's more common and it can be treated. So 1 in 5 after menopause. And then think about cancer treatments in general. If you have a hysterectomy for reproductive cancer, you're in surgical menopause. Or if you have hormone suppression because maybe you have breast cancer and they don't want a drop of estrogen in your body, you're technically in menopause. So down here, the lower statistics, which you probably have already kind of gazed at, are specific to cancer treatments. There seems to be an epidemic of breast cancer around here, and there seems to be a lot of research. Good job. Let's keep researching and moving forward in that area. So look at these statistics: breast cancer survivors, high incidence of things happening in the genital or urinary system. And then a high percentage of them having sexual dysfunction, something going on with their sexual functions. And then this statistic, it's from 2010. So I think this has actually gotten better from what I've experienced in the profession here. I think doctors and cancer centers are screening better for sexual dysfunction during or after cancer treatments. There are some screening questionnaires you might be given to check off, yes, I have this, or maybe a nurse or a PA in your oncologist's office might say something like, how's your bladder been? Or, are you thinking about resuming sexual functioning? And let's talk about that. So I do think that's being screened for better than 2010. But if you are not screened for it and you have a problem, speak up, advocate for yourself. So hopefully from tonight, you'll get some information and feel comfortable about bringing these things up with your healthcare provider. And remember, the pelvis is bowel, bladder, and reproductive. So I couldn't leave anything out for bowel and bladder, or bowel cancer and bladder cancer. So people who have the colorectal cancers, before cancer treatment, if they're having, normal stooling, control of their stools, after cancer treatment, which I think radiation is a biggie in rectal and colon cancer, nearly half of those patients will end up having maybe transient, maybe not permanent, but even transient loss of bowel control. And then some of them will go on to have even bladder control issues. And then a low percentage, 14%, have rectal cancer, maybe radiation to the tumor in the rectum. And you might have both, which is kind of a double whammy. And think about the breast cancer, ladies. Breasts are part of the reproductive system. They're target organs for estrogen, the hormone estrogen. So are the ovaries, so are the uterus. And what many women don't know is that parts of the bladder, especially the base and the urethra, need estrogen. So I think the ladies with the breast cancer, so much is focused on the chest and upper, and maybe you're going through treatment or you've survived that treatment, and then you're like, something's different down there. I didn't know I would have problems lower. I thought this was all chest and breast. So that's something to know about if you're going through that. So these problems are more prevalent than you think. Start talking to your friends, start talking to your healthcare providers. Cancer treatments specifically, why do they contribute to these pelvic health problems? There's direct reasons and indirect reasons. You could see right there, the surgery is pretty direct. If you need a necessary surgery to remove an organ, to move an organ, to connect something or disconnect something, that's going to create a change in the space, a change in the pressures. This bowl of support is going to be different. The support structures inside the bowl will be different after surgery. Muscles oftentimes weaken when you enter the abdominal cavity for surgery. And then body's always going to heal no matter what with scar from a surgery. So scar can cause problems. And then if you need radiation from cancer, that radiation is aimed at the cancer cells, it beams at them, it gets rid of them. But in the surrounding tissues, you usually have swelling and you can have a change in the tissue. It may not be as pliable, so it may not be as strong. And then if there's swelling from radiation, that could be pushing on nerves or irritating the organs. Indirect effects from cancer treatment, chemotherapy. I've been told there's technically something called chemobladder, that people that go through chemotherapy for cancer anywhere, it could be some other kind of cancer in your head or neck. If you're having chemotherapy, chemobladder can occur because if you think about it, the pelvic organs are organs of storage and elimination. So that bladder, all those chemotherapy agents, which is flowing through the rest of the body, sits and gets concentrated for possibly a normal 2 to 4 hour interval. But what it's doing is irritating the lining. And so the most frequent and common symptom of pelvic health problem of chemo is that urgency and frequency. That bladder will get irritated. So you might not know that, but all of a sudden you're going to the bathroom a lot and those urges are strong and maybe painful or irritating. And then the hormone suppression. If you have a reproductive cancer and they want to drain your system of estrogen or on the men's side, testosterone, again, that makes those early menopausal changes and tissues change. We're going to go through each of these pelvic health problems and discuss them a little bit and what you can do for them. Self-help. There's a lot of things you need to depend on your doctor for, your radiologist, your nurse information, but I'll be here to give you some self-care tips. And then remember, I'm the exercise person. So when we get to that Kegel exercise, we're going to go really deep into that. So there are different types of bladder leakage, and you can have an urge leakage, like you get that strong sudden urge. Sorry about that. And before you know it, the bladder has squeezed and out comes the urine. So this lady might have a strong urge. It looks like she might be late running to the meeting, but maybe she's late because she had a strong urge and she had to stop in at the bathroom. Oh, I can't make it through the meeting unless I go now, and then she's late. Or maybe she's in the meeting and she can't concentrate, that urge is strong, so she has to run out. So that's urge incontinence. You're leaking on the way. The bladder's already squeezed, the urine out. At the same time, instantaneously get that strong urge. And then there's a stress incontinence, which actually is the most common bladder leakage pattern, men or women. And this woman looks like she's under some emotional stress, like maybe she's going to cry, but actually she's getting ready to sneeze. So it's not emotional stress, but she may be in emotional stress because she's got this problem. It's physical stress. So, that's a lot of change in pressure. The air pressure pushes down and out comes the urine. The other times people with stress incontinence leak are right here: jumping jacks and exercise, squats and jumping jacks, lunges. All of a sudden I leaned forward or I lunged forward and I leaked. You can have a little bit of both kinds together. You could leak on the way or leak with coughing, sneezing, and that's basically called mixed incontinence. There's another type of incontinence. It's not as common during or after cancer treatments, and it's not something that my exercises that we're going to go over, that I'm going to teach you, can help much. But I just wanted to tell you that just in case you hear it and you want to know the difference about it. It's called overflow incontinence, and it happens like in spinal cord injury patients like Christopher Reeves and people whose nerves have been severed at the spinal cord. So there's no nerve impulses to the bladder at all. So it just keeps filling, and it gets so big that it spills over. And that's really more a neurological problem. Okay, and it's managed through medications or self-catheterization or a catheter. Just wanted you to know that. But These are the two main kind that women of all ages, all stages, and cancer, post and during cancer treatment can experience. And pelvic floor exercises, which we're going to talk about, the Kegel exercises can help, and physical therapy can help teach you those. Remember, aerobic exercise for heart health, weight-bearing exercise for bone health, and Kegels for pelvic health. I'm going to move on to those prolapses, those dropping organs. On this side, you see what the normal position of the organ should be. This is your bladder right here, out the urethra, vaginal canal, uterus kind of on top, and then anal canal and rectum. But if you start having support problems, ligaments and muscles get weak or too much pressure from above, here's a picture of that cystocele where the bladder kind of falls back into the vaginal canal. And then if the uterus starts to come down, you have a uterine prolapse. And then think about those ladies that have a hysterectomy, take this out, the uterus, for whatever reason, fibroids, cancer, whatever, and you've got this large space between the bladder and the rectum. So that how those things fit in there, where you're sitting in the orchestra, gets all changed. So here's the statistics for dropped organs. I think if you have a baby, there's a high percentage you have a little bit of this and you don't even know it because that baby's been pushing down for 9 months on your organs. And that has been confirmed by a gentleman named Hagen that a small degree, you can be walking around and not even knowing it. If you've had a child, a small degree can be seen in as high as 50% of women who've had children. If you have an organ droppage, it's highly likely that you have bladder leakage. Those two kind of go hand in hand. But on the flip side of that, it kind of depends on which way the organ can drop. If it drops for some reason and kinks or obstructs the urethra, then you could have one of those emptying difficulties, voiding dysfunctions. Instead of leaking, you can't empty. It kind of goes either way, whichever way it shifts. And then there are tendencies, there are predisposing factors to put a woman in a category to have a dropped organ. So if you are in one of these categories to begin with, and then put on top of that, having to go through cancer treatment and survive cancer, that might be a little more predisposition for you. The predisposing factors are heredity. These tend to run in families, your mom and your sister and your aunts and your grandmas, so you can start asking around. Parity means the number of children you've had, the more pregnancies you had, that kind of sets you up for this. Hysterectomy, here's that statistic again, high percentage after hysterectomy. Culture, Asian or Hispanic women tend to have more of this, and I believe I've heard that's because of their collagen makeup. Every gender race has a different makeup of their collagen, which is the support structure of the body. So they might have a different makeup of their collagen based on their race or culture. And then weak pelvic floor muscles, but we're going to talk about those, and exercise for pelvic health is the Kegel, and therapy can help. There are treatments that are non-physical therapy for all these problems. For example, that urge incontinence, I'm sure you've all seen the commercials, gotta go, gotta go. And then there's that drug, a couple of them are like Metrobeek, Detrol. There's a whole class of those drugs. They work for that urge incontinence and urgency. They work by relaxing and calming the bladder. And then there's, for the stress incontinence, there's also some surgical procedures for that. For the dropping organ, there's definitely surgical procedures, but there's also sometimes if you've gone through a major cancer surgery and reconstructing, and then the doctor says, you need to have your organ dropped, you need to have another surgery. And you're like, absolutely not. There are other options. That's why you need to know them and be able to advocate and ask questions. For example, I had a call from a lady several months ago, and I think she was referred from Gilda's Club, so thank you. She was a lady that had gone through hysterectomy for cancer, and she was just distraught because she's like, here, I went through major surgery, and I think it was only like 3 months 3 months ago or something like that. She's like, now they tell me I need another surgery because my bladder dropped and I don't want to do that. And I'm not even healed. And so, can you help me? And I said, the exercises you definitely, can get stronger. We could always try to get you stronger with exercises and pelvic health, lifestyle changes, learning how not to put more pressure on your organs. And I said, talk to your doctors about options. There is an option. It's actually called a pessary. You've probably read it while I was talking. It's a brace to hold your organs up. So some women can use that and get by without having a second surgery. And then again, strengthening the muscles and learning good and bad ways to move so that when you bend over, you're not pushing your organs further down. That's my job, to teach you self-care and exercise. So coming to a therapist like me can help for those issues. And then in conjunction with your doctor, your oncologist, your nurse practitioner, we can all make you out the best care plan. And then for the sexual dysfunctions, we talked about the 3 ones, but the main one is the painful intercourse or dyspareunia, the most common sexual dysfunction experienced by women in general and by women during and after cancer treatment. The number 1 cause of painful intercourse is a medical term, vaginal atrophy. It means the tissue is changed. That means dryness. Your tissue, your vaginal mucosa is not making the same amount of lubricant or lubrication or mucus. And then the tissue is different. It's not as strong. And so, sex is a lot of movement. And so the tissue's more fragile and dry. So sex becomes painful. So the least, if you've gone through cancer treatment and end up having this kind of problem, the least your healthcare practitioner should do, talk to you about when and if you're going to resume sexual intimacy or options to penetrative intercourse, if that's not possible, and discuss lubricants with you, because a lot of women don't know that. And something as well as knowing to use a lubricant or good lubricants or which one's good for me. And when the Q&A comes up, somebody remember to ask me a question about lubricants, because I could go on and on right here, right now, but let's talk about lubricants, because there's ones that have a lot of chemicals, there's more natural ones, there's ones that deal with your pH, and that you probably have all heard that the vaginal canal has its own specific pH. Is it acid or base? And if you get that right, say with a lubricant or with suppositories to make sure you've got the right environment, things are much better. The number 1 reason for the vaginal atrophy is lack of estrogen. So just postmenopausal women and those women that go through estrogen depletion because of reproductive cancer. There are other reasons for pain with intimacy. They could be scars from a procedure. It could be muscles. Now the muscles in the area, so it could be from them. So if you get educated on lubricants, you try everything your doctor says, but maybe it's muscle, maybe a physical therapist could help me. And physical therapies work with scars too. We teach you how to work to soften a scar that might be tugging on that area, that vaginal canal, and causing some of the issues. I put this picture of vaginal dilators. Some of you in the audience, I had somebody in the audience a few lectures before, and she said, oh, I know what those are. She had rectal cancer. She had a tumor that needed radiation in the rectum, but her oncologist and her radiation oncologist was smart enough. She said, when they first gave this to me and said, use this after your radiation, I didn't understand it all, but I do now, because during her radiation to her anal canal, that the very next tissue, remember how things are so close, that vaginal tissue could tighten up, scar down. So for her rectal cancer treatment, she was to go home after radiation and insert what's called a vaginal dilator. They can be very scary, but insert it so that that vaginal canal can stay pliable. Just for the box says 10 minutes. There's different protocols, there's different sizes, there's different textures. And I am not a cancer survivor or haven't had cancer, but I can just imagine someone handing you this box and saying, here, use this. Well, what do? Oh, go home and read the box. And it says, insert as far as possible for 10 minutes. Well, wow, I wish somebody would help me here or talk to me or sit me down and give me a choice here. So do know that physical therapists can help with that. Some women come to me and they've already have a set of dilators. They only have one dilator and it's maybe not the right size for them. Maybe it's too hard and they would like something softer. So that's something that I could help your other practitioners with. I could give you that one-on-one personal time if this becomes part of your cancer treatment for pelvic health. A lot of research, I'll tell you, when I deal with women with this, I got the Kleenex boxes, and rightfully so. This is a very, very emotional topic, rightfully so. This is like striking at your womanhood. So I cry, they cry. It's crying is good. Get it out. Let's figure out how I can, resume intimacy comfortably. Research shows that women who have sexual dysfunction get the best results if they do all three kinds of treatment: medical treatment, doctor, nurse, what do I do? Physical treatment, what can you do? Therapist, teach me how to take care of my tissue. Is my muscle tight? Maybe my scar is causing this. And the talk therapy, the emotional therapy, talk this out. Don't keep it inside and say, I'm less of a woman. So I just wanted to put that out there. If any of you have experienced that, you know what I'm talking about. Let's move on to the Kegel exercise. Because I've been telling you this, that's the general exercise for pelvic health. A lot of women know about Kegel exercises when they're first pregnant and their gynecologist says, oh, by the way, squeeze your pelvic muscles like you're holding urine 10 times, 3 times a day. Do your Kegels so you don't leak after you birth your child. Well, that's good verbal advice, but remember, these muscles are the deepest muscles in the body. You don't see them if they've been stretched out from or scarred from procedures, or maybe they're tight because they've reacted. Muscles have protective reflexes. Maybe they've tensed because of issues in this area, surgery, trauma, whatever. You may not be able to contract or relax them. So Kegels are very, very difficult to do correctly. This is why I have a job. This is what puts food on my table. Usually I like to put very current research in my presentations, but look at this. It goes back to 1998 because we knew it over 20 years ago, and I've been doing this work for 23 years, and it still rings true. Research shows that 50% of subjects do not correctly contract their pelvic floor muscles if they're just given a brief instruction. Oh, just squeeze 10 times, written or verbal. So what if you get a handout and this picture's on it? Okay, there's an arrow from front to back. What does that mean? Look at this picture. Does that arrow go from front to back, or does that arrow push straight down? I don't know. I don't know if I can even feel these muscles. Look at this lady. She's pregnant. I think she's pregnant. Yes, that's when most of us women start doing our Kegels or are told to. But am I squeezing my stomach? Wait a minute. This isn't moving. Maybe I'm holding my breath. So it just goes to show you that when you can't see it, when something's wrong, like they're stretched or they're tight and you can't feel that, it's going to be difficult. So, just do your Kegels, you might need a coach. And that's what I do. So your pelvic muscles, it's a little more complicated than Dr. Kegel, I think, described in the 1950s and 60s. What we know about the pelvic floor muscles, and you can see them on my screen, you can see them on my slideshow. I already told you they're the deepest muscles in the body. There's 3 different layers. It's not a muscle. It's almost nearly 30 muscles in this area, layered in 3 different specific layers. These muscles have 3 important functions. Sphincteric. Sphincter is just a medical term for circular. So you have 3 sphincters down the midline of your body. You have the anal sphincter, and it's kind of got a mind of its own, meaning it's got a nerve all to itself. So we can have an isolated anal sphincter contraction. We can learn how to do that. We can train that. If you have fecal incontinence, stool accident, say after rectal treatment, that's where we want to focus. There's your anal sphincter, you have a vaginal sphincter, and then you have the urethral sphincter. So the sphincters are in the first and second layer, they're midline in the body, and they contract circularly, okay? You have a supportive function. We talked about those organs dropping. So as you can see, that's between your legs, the floor of the pelvis, that's why it's called the pelvic floor, is muscular. So it has to have strength yet flexibility to compensate for the weight of the organs. So if it's weak and dropped, that's when those organs drop. If it's tight and doesn't accommodate when you jump, then that can be an issue too. So that third layer is your lifting layer, lifts from the bottom inside. And then the third function is a sexual function. The pelvic floor muscles are responsible for climax and orgasm. The muscular part of it, which is that nice, wonderful nervous reflex. We have arousal and stimulation, things feel good. And then these muscles tense, and then, wow, that felt good. Let's go eat some ice cream. So muscular, climax, those two go together. And then nerves are tricky because you got to wean out, make sure there's no nerve damage or nerve problems. There's 3 types of contractions. We already kind of talked about it. The sphincter is going to have you can have an isolated sphincter circular contraction. You can have a combined sphincter where you pull from the back to the front, almost like a drawstring or a zipper. You can squeeze rectal, vaginal, urethral, drawstring contraction. That's the second contraction the pelvic floor does. And then that third is the lifting up and in. So very, very complicated. So just do your Kegels may be overwhelming if you have a problem with these muscles. These muscles are red, skeletal, voluntary. We learned how to control them as a child when we were potty trained. So if we lose control as an adult, we can go back, we can relearn the same kind of relearning we did with potty training. Muscles, my bread and butter. So it's weakness, it's endurance, it's coordination, it's flexibility, and it's awareness. So all 5 of those problems can be in your muscles, 1 or all 5. And so maybe you don't have a strength problem. Maybe you have a coordination problem. They come in late and the urine has already leaked out. So that's why Kegels are very complicated. And that's why if you have problems and just handing you a handout isn't working for you, advocate for yourself and say, maybe I need to see someone that could help me with these Kegels, get my bowel, bladder, and sexual problems improved, help myself. The muscles weaken automatically with age, hormonal changes, then trauma, radiation, just disuse, use them or lose them. That's the same mantra for these muscles as every skeletal muscle, use it or lose it. And then the organ support problems. So those are your pelvic floor muscles. If you need help with these, if just reading or somebody telling you how to do them isn't working for you, I can bring them to your vision. I use EMG. So here you see the model. She's turned sideways. These are skin patches, so they can go through clothing, through depends, onto this area between your sit bones, pubic bones, and tailbones, this bony diamond, and monitor, just like an EKG monitors your heart beating, and heart is a muscle. It's an automatic, not a voluntary. So an EKG shows you your heartbeat. My EMG will show you your Kegel, like down here. So how long are you holding? Are you holding for 3 seconds? Are you holding for 10 seconds? Can you contract? Can you relax? Also, if the line's going down, but I look over and you're like, I'm doing it. Why is my line going down? Well, then we have to figure out, maybe it's a little more complicated for you. Maybe you're using other muscles. Maybe you're just holding your breath. Let's work on that so you can help yourself. There's other ways to feed back information. There are vaginal weight sets here, which are actually very, very high level. If you can lift weights with those pelvic floor muscles in the vagina, you probably don't need me. But so I don't use vaginal weights a lot, but many times when someone has gotten really good with their pelvic floor and they don't need me anymore, they don't need the teaching, but they want to keep getting stronger and stronger, I might suggest these and they might use them 3, 6, 9 months down the road. Every now and then I'll get a phone call from a lady saying, I got these in the back of Oprah magazine and what's wrong? I put one in and it falls right out when I stand up. Well, they are high level. So if it falls out when you stand up, you probably are so weak that you can use these laying down to give you that awareness. If you feel you're laying down and you're so weak, but you feel that you're trying to draw that weight up and in for that lifting contraction, some people, even low level, could use these. There is a device called a pelvic floor educator here. This is intravaginal. It goes inside the vaginal canal. And then this funny thing is outside your body. So yes, if you look down and you're using this between your legs, you will see this, like they call it an indicator coming out from between your groin. Why would you ever do this? Well, it is awareness again. Because the only thing, if this is intravaginal and you tighten those muscles to pull up and in and draw that up and in, that little indicator will point down to your feet. So you will know, oh, I must be doing it correctly. If for some reason you're trying your Kegel really hard and for some reason that points up at your face or it comes out of your body, you are pushing, which, believe it or not, every now and then somebody comes along and I say, show me your Kegel, or I put them on the machine. And instead of pulling up and in, they're trying so hard, they're bearing down and pushing out. So if that's how you do a Kegel, by just reading or someone telling you, you're going to make things like a prolapse or stress incontinence, you're going to make that worse. So yes, these are weird devices, but if appropriate, they can help. Think about this too. These are vaginal devices. What if you're one of those ladies who has pain with intimacy, or you have vaginal reconstructive surgery? Is this something you should order on your own out of a magazine? I don't think so. That's something that, we can pick and choose what's going to help you learn muscle awareness, what's going to help your problems, okay? So maybe you're doing the Kegel exercise well, and you do 10 in the morning, 10 in the evening, and 10 in the night, and you're really proud of yourself, and I'm proud of you too, because you're looking better in my computer. But there is a training component. For example, I have ladies that say, oh, you're going to teach me Kegels? I do 100 of those a day, which, by the way, Dr. Kegel said when he came out with this in 1950s and 60s, do 100 to 150 Kegels a day. So ladies were counting to 100. If you're doing that many, these muscles should be working automatically when you need them. For example, okay, if you're doing 100 Kegels a day, do you do one before your sit-up? Have you trained yourself to find, feel, and pull those muscles, tighten those sphincters so that when you sit up, you don't dribble urine? Do you do that have you trained yourself to, when you pick up groceries, to do that? When you feel chew, if you're quick enough, that this technique is called the knack. You feel a sneeze coming on, can you right away get the knack, tighten up? And a lot of ladies can catch those leaks with sneezes. And if you do this enough, it becomes automatic. So yes, you can do Kegels, but have you trained yourself to use those muscles functionally? For example, like Venus Williams and Tiger Woods, we have their great tennis serve and their great golf swing. Don't you think they practiced it over and over? Don't you think they took that golf swing or tennis swing and broke it down into components and did one component, then the other, put them all together? Don't you think they're closing their eyes and visualizing themselves, this mind-body connection, making this brain-body connection? Seeing themselves do their serve or their golf swing so that in their sleep they can do it. They don't have to think about it. It's Venus's serve, it's Tiger's swing. That's where I want to get you with your Kegels, so that, no, you don't have to, oh God, I got to do 100 Kegels a day. No, you don't. You've trained yourself that those muscles are automatic. Okay. Besides the Kegel exercise, there's other of those self-help techniques, pelvic health techniques, lifestyle changes. What do you do during your life that might help you with pelvic health? Well, if you've got that urgency frequency problem, we might talk to you, me, your doctor, your nurse practitioner. Sometimes the therapist is the main one that does this. We might talk to you and have you fill out a bladder diary, come back, and then see, you know what, we're going to put you on timed voiding. So let's have you go every hour and a half before you get that strong urge, before it's running down. And then if you do that for a couple weeks, then you notice, oh, you know what? I'm not getting that urge but for 2 hours, whereas before I was getting it sooner. So when we learned as children, sometimes potty training puts kids on schedules. Okay, let's go to the potty now. You train your bladder, you can train it as an adult. So timed voiding or bladder training is part of pelvic health, what a therapist, nurse, practitioner can help you with. When people get those strong urges, there are techniques to suppress them. I'll tell you now, here's another pelvic health factoid. Many times it's perfectly fine to ignore a bladder urge, and sometimes you need to, but don't ignore a bowel urge. And the difference being is the bladder is a really sensitive organ. It can kind of contract and give false urges even when it's not full, when it's irritated, because it's a thin, fragile organ. And so sometimes if you're training yourself, yes, you have to ignore it, use urge suppression techniques. I'll tell you what those are in a little bit, and see if the urge where you feel like right here, I better run to the bathroom, the urge is a nervous signal. It can fade, believe it or not. A lot of people say, no, I'm going to pee my pants if you tell me just to sit there. Many times they do, until they've trained themselves to let that nervous urge, let that bladder quit contracting, calm down, and then they can stand up and they can go, oh, I don't have to go now. That's urge suppression techniques. Most of those are sit down, squeeze tightly, distract your mind, count backwards from 100, recite a poem that you knew in grade school, something to allow that nervous urge to come back down, because truly the bladder might just be irritated and not really full enough to empty. The worst thing you can do with an urge is what these two people are doing, the potty dance. If you jump around, that's going to make that bladder more liable to contract. Other pelvic health, like lifestyle things that are important. If you have that urgency and frequency because the bladder is irritated, say chemo bladder, some of these foods and fluids, all the good things, caffeinated drinks, carbonated drinks, those acid bubbles, those bubbles are acid that pop in your bladder, caffeine, which is a stimulant, alcohols, all the obvious good stuff, those are going to make chemo bladder or urgency frequency worse. So if nobody told you that and you have that problem and you're drinking your 3 cups of coffee in the morning, you're making yourself more miserable. And that, if it's like a chemo bladder and the bladder's irritated, this is not like a forever thing for some people. It could be just transient, and let that bladder calm down. If the chemo agents get out and the bladder can heal back, then maybe this isn't an issue for you. And then another lifestyle technique, thing to know, factoid, is how much fluid. If you leak, a lot of ladies, oh, I leak, so I'm cutting back on my fluids because if I don't want to drink more because I'll leak more. Well, that means your urine will be more concentrated and have more stuff in it and might irritate your bladder and make you leak more. So a normal fluid, is there a normal fluid intake? Most of us have heard drink 64 ounces a day, 8-ounce cups. Well, it can vary. If you're a very petite woman, that might be overhydrating. Or if you're a very large, full-framed person, you may need more. So a general factoid, a pelvic health factoid, is you should get the fluid ounces in a day that's half of your body weight. So say you weigh 160, divide that in half, 80, then put ounces behind it. So that is the amount of fluid ounces, total fluid ounces to get in a day for normal hydration. And then that formula, if you get into the category of like, there is a category of like morbid obesity. If you're really, really big, that doesn't mean you have to keep drinking and drinking. So somewhere, and I'm sorry right now, I know that poundage, but for the general population, that's a good rule of thumb. Except if you have kidney problems and you've been told by your doctor, if your kidneys aren't filtering, they're not making urine. So some people with kidney problems, because that's where the urine's made and then it dribbles down, sometimes their doctors will want them to restrict so their kidneys don't have to overwork. So there's in a nutshell your pelvic health general knowledge for fluid guidelines. I think we're close to trying a virtual Kegel. It's now about, I think I've got 5 or 6 after, and we started about that late. So we're at an hour mark. This will probably take between 7 and 8 minutes. I usually take people through virtual Kegels, which is really interesting. Remember, 50% of you are going to get it and 50% of you won't, because on average, with just a brief verbal instruction, which is what I'm going to do, or written, if this is your handout your doctor gives you, if you have a problem with these muscles, it might not work. It's fun. And we do everything on Zoom, so why don't we do Kegels? So a few things before we do our virtual Kegel trial is, I might have hinted at it so far, mind, body. Kegels are harder than you expect. So we really have to focus and tune in, reconnect mind to body. Where are these muscles? Can I feel them? Can I find them? Can I activate them? So this picture from a PT magazine, I love it. The whole issue was on women's physical therapy. This woman is doing her Kegels. Proper technique takes mindfulness. Mindfulness is kind of the buzzword, meaning let's be in the present moment. What am I thinking? What am I feeling? Can I connect to my body? So we're going to be very mindful here in a minute or two. Another thing is visualization. Most people don't even know the muscles in this area, but when they see this, it becomes more visual to them. Okay, so these muscles, as you can see, they're in this bony diamond. This is the pubic bone on both sides. These are the sit bones. So in a second, we're going to find our sit bones. We're all sitting. And then in the back is the tailbone area. So just remember, these muscles are between this bony diamond that's between your legs. So that's the area you're going to want to find, feel, and move. True pelvic floor contraction has no bony movement. So if you feel your hips tilting in the chair, or if you feel your hips rising, those are other muscles. So think of this area between your bony sit bones as where you want to find, feel, and activate. Those sphincters are circular muscles, so they contract circularly. Get a visualization, and I'll be cueing you when we do our virtual Kegels. A sphincter muscle, if you have visual or kinesthetic, which means body awareness sensation of something circular, you may be able to visualize that and get a sphincter contraction. For example, if we want that isolated sphincter to move, many times it's pucker your lips, like pucker, okay? Or wink, or close your eyes and squint tightly. And that's the same visual and kinesthetic contraction of your sphincters, okay? If we want an isolated sphincter, you might hear me say, pucker your anal sphincter, pucker your anus, or do an anal wink, okay? Then remember, we have another kind of contraction. We have a combined sphincter. So we can tighten our sphincters, rectal, vaginal, urethral. So we can get, when we cough and sneeze, we want all those tightened up. So a combined sphincter, you can get an image from back to front. So these middle images, a zipper, think about a zipper from your tailbone zipping forward to your pubic bone, just between there, no bony movement. or a drawstring. You know how you pull a drawstring and it closes in a circle. So here's the drawstring. Or this is a weird image, but some people, when you're visualizing, some visualizations work for some people and others not. So I'm throwing these out. They're weird, but if something clicks with you and can help you connect, let's go with it. So the hammock, your thigh bones here with your sit bones, the sit bones are right where the hammock is attached. So you're swinging your hammock from your tail to your pubic bone. So you're swinging your hammock from the back to the front to get a combined sphincter. Achoo! You want to tighten those all up. And then for that lifting contraction up and in, the most common visualizations is the elevator exercise. You know, you're at the bottom floor, pull inside, up and in, floor 1, floor 2, floor 3, and then release back down. Other images that can be used for the lifting is you have your sphincters puckered on that straw. Now draw in, suck up and in on the straw like a vacuum into the pelvis, inside the pelvic cavity. This is a weird one, but actually a patient of mine used it and it worked just fine. And again, like I said, mind, body, whatever clicks for you. So she saw this pelvic model. She saw this bony frame and this shell. And she said, oh, you mean like a turtle going in the shell, like pulling inside. So whatever works for you. Weird, but it always is. And if it works, that's great. So we will visualize. And then we'll try to find if we're cheating. Here's the most common ways if your muscles have poor awareness or are weak and you can't find them or sense them. This is usually what happens. The number one cheater is holding your breath. So you will definitely know you're holding your breath because we're going to have our hands on our chest here in a second. And your chest and your stomach has to rise and fall with your breath. So if I'm saying, okay, draw your elevator up and in, and you don't feel your hands moving, more than likely you're holding your breath. Another thing that happens is, oh my God, I'm doing my Kegel. It's basic human nature. When we put out effort, we try to hold our breath and bear down. Oh, this is heavy, I'm going to lift it, which we all know that's probably the worst thing we can do. And if these muscles are trying to come up, but we're pushing down, how's that going to work? So bearing down, you will feel that your belly will harden and bulge. Okay. And how is that pelvic muscle going to come up? We already talked about there's no bony movement with the proper Kegel. So if you're sitting in the chair and you feel your butt lift or your head rise towards the ceiling, you got to be squeezing the buttocks. As you come forward, say on that combined sphincter, a lot of women, as they go forward, holding your bladder, you might roll your thighs, roll your knees together and feel your groin muscles tense. So no thigh rolling, no knees rolling, or that means you're using your groins. And then we will have a hand on the abs. The pelvic floor and the abdominals together are part of your core. And a lot of people in like gyms, that's a buzzword. Let's do core exercises, which that's a lot of abdominal work. Pull your belly in, hold it, suck in your belly. If you've got abs that are stronger than your pelvic floor and you feel your abs get rock hard, but you feel nothing below, sometimes your abs can push down and that's going to worsen prolapses, or that's going to worsen the stress incontinence. And you may be saying, I'm doing my Kegels, but I'm still leaking. Well, too strong abs and weak pelvic floor might not get you the results you need. So I think we're ready. First off, take your hands. This virtual Kegel will take about 5 minutes. Take your hands, palms up, and shift side to side. Nobody, if you want to turn your video off, you can. Nobody's going to see you. But shift side to side and put your palms up underneath each buttock. Right hand under right butt, left hand under left buttocks. And make sure that your palm, you shift side to side and see if you could feel your sit bone. When you shift side to side, you're going to definitely feel your sit bone in your palm. Try to focus that the palm is where your bone hits. And then your fingertips are going to be touching, overlapping each other. And yes, your fingertips will be on your pelvic floor, on your outer labia. Take away the skin layers, deep, deep, there's your pelvic floor muscles. So shift side to side, make sure your sit bones are in the middle of your palms, Make sure your fingertips are touching and or overlapping between your legs, yes, on the outer labial through clothing, okay? When you think you got that, side to side, try to find a happy medium. And then we're trying to find that bony diamond. Now go between a slump sit. If you slump in your chair and round your back, you're going to feel your sit bones go forward in your palms, and then come back to upright, and then do what therapists call perch sit. Perch sit is you lean forward, tip your pelvis forward, maybe lean forward towards the front of the chair. So you're going between slump and perch, and see what that feels like, because you're going to find those sit bones sliding forward and backward in your palms. Before you felt them side to side, now you're feeling them slide forward and backward. Find the happy medium here. So when you found the happy medium between your side to side shift and your forward backward shift, you feel those sit bones in the middle of your palms with your fingers overlapping. You have your bony frame in the perfect position to activate those muscles, okay? Right now, before we even give you any coaching, do what you think is a Kegel, holding gas, holding urine, and your hands are still under there. Hopefully, some of you have felt something tense, maybe a lot, maybe a little, something move underneath your fingertips, not your sit bones, okay, not your buttocks, not rising in your chair, but a little tension in that tissue where your fingertips are touching and overlapping. That's your pelvic floor, okay? So now that you got that, take your hands out, put one hand on your chest and one hand on your tummy. Close down your eyes, turn inward, be mindful, let your mind feel and see and visualize what you're feeling in your body. I'm going to be quiet here, and I want you to take maybe 3 to 5 breaths and pay attention to what's happening under your hands. Go ahead and breathe deeply, breathe normally. Okay, some of us are chest breathers, some of us are belly breathers. Most of us have a little of both going on. So I'm hoping what you felt was your hands rising and falling with your inhale and exhale. Because when I say tighten up, lift up and in, you want to check in with your hands and make sure you're not holding your breath. Still with your eyes closed. Now, take in an inhale and then push that breath down like you're pushing out hard stool or pushing out, if you've ever given childbirth, pushing out baby. What you should feel, hopefully, you feel your belly bulge and harden. If, oh God, I'm trying these Kegels, if that's what you feel, you're working against yourself and you're going to make your pelvic problem, say prolapse or stress incontinence, worse. Okay, hopefully we're all tuning into this because we're going to be moving on now. Okay, does it make sense that your pelvic floor, if it's going to come up and inside the pelvic cavity, and we just discovered air in or bearing down is going to prevent that, doesn't it make sense that I'm going to cue you on an exhale? As you exhale, I'll cue you, exhale, then we'll do our pelvic contractions, isolated, combined, and lifting contractions. So take a breath in, and on your exhale, let's start with finding that pucker or that wink. Can you do an isolated anal sphincter like you're holding gas, gas only, on your exhale? Now, you're probably gonna have to take another breath. So check in, can you breathe up high but still hold down low? Check in, are you raising in your chair? Is that butt squeezing or is it just that anal sphincter? And release. Some of you might have felt that. Some of it might have faded by the time I said release. I'm not sure. But that's your isolated sphincter. The blinking, squinting, or puckering. Let's try that once again. Inhale. And on your exhale, wink, blink, pucker, isolate that anal sphincter. Can you breathe up high, hold down low? Make sure you're not lifting and squeezing the buttocks in your chair, and release. Still with eyes closed, still with hands on chest and belly. Take an inhale. On your exhale, visualize, pucker, wink, anal squeeze, moving forward into that combined contraction. Visualize drawstring, zipper, hammock back to front. Can you move forward like you're holding urine, holding your bladder with that combined sphincter? Check in with your breath. Can you hold down low, zipper, drawstring, hammock swung forward, breathe up high, and release. Let everything go. Inhale again. On your exhale, we're going to do all 3 types of contraction. Exhale, start at that anal sphincter, pucker, wink. Draw forward, zipper, drawstring, hammock swinging, tailbone to pubic bone. Lift, elevator, suck on that straw, turtle in the shell, up inside, tissue inside. Check in. Can you breathe? Can you hold? Are you squeezing your buttocks? How are your knees? Are you tensing? You shouldn't be lifting or rolling in your chair. It should all be inside. And release. Completely let everything go. Gosh, this is mentally exhausting, isn't it? We're going to do one more total combined, all 3-layer contraction, and then we're going to go to we got about 10 minutes for a question and answer. This is weird, but this is relearning something that might be very necessary. Okay. Eyes closed, hands on chest and belly. Inhale. On your exhale, first isolated sphincter, wink, blink, pucker, drawing forward, holding bowel, holding urine, zipper, drawstring, hammock. Now lifting up inside, elevator, first floor, second floor, turtle in the shell. Check in with your breathing. Can you breathe high but hold low? Are you just squeezing your butt? Are your knees rolling in? Keep them straight. And release. Release everything. Melt into the floor. Remember, sometimes you can have a stiffness problem and maybe these muscles don't release or are scarred down in a scar. Some people have to work on releasing before they can learn how to contract. All right, that's our virtual Kegel. Open your eyes. Thank you for coming. We're going to open this up to, 7 minutes maybe? This was till 7:30.